you need anything? Yeah, I know. He's gonna tell me pancakes and.
Yeah, a little surf and turf.
Close the door. We're good.
Yeah, I guess in case it gets.
Yeah.
Gets
They'll come by with the vacuum.
Yeah.
So just
That's right. Yeah, let me silence things. Hold on a second.
Yeah, whenever you're ready.
Oh gosh.
It's Agostino.
Agostino. Yeah, or well.
I'll end up being say Dr. Cervoni most of it.
Cervone. Yeah, in Brooklyn, my cousin's Cervoni. I don't know. It doesn't really matter. What the hell?
No, Cervoni. No, just when we do the introductories and stuff, I'll.
Okay. They call me Tino.
Tino. They call you? If I call you Dr. Tino Cervone?
No, call me Agostino Cervone, but then, you know, you can call me Tino after whatever.
Okay. Oh, what do you want?
Mic doesn't work.
What mic does?
Oh. I had nothing to do with it. I didn't touch it. I got the blue mic.
That sounds silly to have working microphones in radio station.
Right? Who would have thought? So silly.
Hello, can you hear me now?
I'm just standing on the side here for do pictures.
Not a
Like
problem.
a star.
All right, you ready?
I'm ready whenever you are.
All right, in 3, 2, 1.
And hello, everybody. I'm Bill Powers on 103.9 LI News Radio, and welcome to Peconic Bay Medical Center's Ask the Medical Expert. With me today is abdominal wall reconstruction surgeon, Dr. Agostino Cervone. He's chief of robotic surgery for Peconic Bay Medical Center. How are you today, doctor?
Oh, I'm doing well, thanks. How you doing?
I'm doing very well. Thank you so much. Now, before I get into the whole robotic surgery situation, when you started out, when you came out, were you just a general surgeon? Or did you specialize in this right away?
Well, I would say that general surgery is a specialty in its own. And
I can't do it.
the true general surgeon is a surgeon that does anything,
right.
From lumps and bumps to all soft tissue things, including what we know now as specialties that include GYN surgery, anything intestinal within the abdomen, including hernias. Probably what general surgeons do the most of are hernias, gallbladders, appendix is probably the most common general surgery emergency, and then lumps and bumps.
Now, why have surgery? Why have surgery for your gallbladder or hernia or whatever? I just scripted that whole thing up. You have to, hey, yo. I don't even know his name. I screwed up.
Ready?
Yeah.
3, 2, 1, go.
Welcome to Peconic Bay Medical Center's Ask the Medical Expert. I'm Bill Powers on 103.9 LI News Radio, and with me today, I'm going to be speaking to Dr. Agostino Cervone. He's Chief of Robotic Surgery for Peconic Bay Medical Center. And welcome, Doctor.
Thank you. It's good to be here.
It's great to see you. Now, when you start out, nobody says, hey, I'm going to be a robotic surgeon. Is there something specific when you come out of medical school for surgery where you do things right away, or is it general surgery? Explain that a little bit.
Well, out of medical school, as you started, you kind of don't know where you want to go. You have an idea of where you want to be. And I would say if you're going into general surgery, you have to have a passion for it, because everybody's got a passion for what we do, hopefully. And so in itself, then that begins the seeking of a residency program. So residency in general surgery. General surgeons come out performing general surgery, which involves anything with soft tissue pretty much. So that's lumps and bumps, breast, thyroid, in the abdomen. Hernias are probably the most common procedure, gallbladders, colons, stomachs. And surgical appendectomies are probably the most common emergency general surgery procedure that we do.
Now, one of your specialties, which is everything, I could tell already, but abdominal wall reconstruction. Why would somebody have to have abdominal wall reconstruction surgery?
So that's become a specialty in its own within general surgery as the years went on. With people requiring operations. In the past, before minimally invasive surgery, they were open operations primarily. Even now, as much as we're doing much more in the way of minimally invasive surgery, meaning small incisions laparoscopically or certainly robotically, there are times where we have to actually make bigger incisions to do things in the abdomen. That in itself has resulted in incisional hernias. So anytime you have an operation like that, and as much as everything is closed up, we don't want hernias to develop or weaknesses to develop or busting at the seams, so to speak. It happens. And so as time goes on and the population gets larger, these hernias get larger, especially if they've been repaired before and it's failed. They then become even larger than they were when they originated.
Now, you'd mentioned as the population becomes larger, are you talking about body size or just in general?
Sure, body size is a part of it.
Big reason. Gotcha. Now, what does this surgery accomplish? Why is this done?
Well, it allows you to have a functional abdomen. So if you consider the abdomen an organ, so to speak, just like you would have a spleen or a liver or what have you, your abdominal muscles are involved in most of what you do throughout the day in terms of getting out of bed and sitting up or turning over. If you have to cough or sneeze, it requires abdominal forces or produces abdominal forces, certainly. So to have a functional abdomen is the main reason for it. The other big reason for it is disfigurement that occurs with abdominal wall hernias, where you have bubbles kind of popping out of your abdomen, so to speak. Mm-hmm. And then the other bit of it is to prevent you from having an emergency where your intestines get locked into a hole in the muscle of the abdomen from a hernia.
And then it just turns into another huge surgery as well.
Yeah, then it becomes certainly more difficult. Yeah.
Gotcha. Now, when you do this surgery, how do you conduct it? Laparoscopic, robotic? How is it done? You mentioned that you don't really try to open up the walls anymore. It could be done very simple with simple incisions. Is that
sure? And that's all depending on the various factors. So the size of the hernia itself kind of depends on how you can approach that. Certainly, hernias that are not so wide. So if you picture a hernia as a weakness, or you picture it like a manhole on the street, but now it's on the ceiling of the abdomen. So it's an actual hole. The wider that hole is, the wider that hernia is, makes it more difficult for it to be approached minimally invasive with laparoscopic techniques. And so sometimes there is a reason to do either open surgery, but now with robotics, it's allowed us to use that even further minimally invasive, in the sense that robotics has allowed entities that are treated mostly open to now be treated minimally invasive because of the instruments of robotics.
There's such small tools that can get in, etc.
It's how the instruments are made, and the main reason is the articulation, what they call wristed instruments,
right,
where standard laparoscopic instruments are straight sticks. Mm-hmm. They open and close at the end of them. But now with wristed instruments, you can actually reach around certain areas that you need to, and that allows you to do a little bit more.
Now, I'm sure some people know, or not everybody does, what causes a hernia to occur?
Well, they happen primarily. There are a number of places for primary hernias, the most common being in the groin. Both men and women will have the most common type of hernia that follow structures that go through the muscle of the abdomen down above the pubic bone on either side. In a male, these are blood vessels going down to the testicles. In a woman, it's a round ligament that's a remnant vessel for that. And so what happens there is that opening that allows those structures to go through stretches even further. And then you have the capability of the inner lining of the abdomen stretching along that as well, and then certainly increasing the risk of certainly pain, and then the risk of incarceration or strangulation of the intestines.
We're speaking with Dr. Agostino Cervone. He's the Chief of Robotic Surgery for Peconic Bay Medical Center. And can you tell me a little bit each about the procedures? There's all kinds of, I guess, mesh, prosthetics, etc. Can you tell us about those and when the differences?
Sure. So over the years, hernias primarily were treated with suture repairs, basically sewing layers together. And depending on where the hernias are, the incidence of recurrence were what they were. So with a typical suture repair of A groin hernia, if, the incidence of recurrence, meaning a hernia coming back over time, is anywhere from 15 to 20%. And then certainly with ventral hernias, hernias in the front of the abdomen, above the groin, with just a suture repair, the recurrence rates can be as high as 30% or even higher than that. So this kind of progressed to use of mesh. And at first, some of these mesh were made out of surgical steel, and as time went on, they became different plastics. Now there's a whole slew of different types of mesh products, from prosthetic meshes, which are made of different plastics, polyesters, to biological meshes, which are made of either human skin, pig skin, as well as pericardium from cows. There's various substances, as well as combined meshes, which combines both biological meshes with a prosthetic mesh. And then also recently there are some meshes that are bioabsorbable, meaning that they have the feel and workability like a prosthetic mesh, but they totally dissolve in over time, in usually about a 2-year period. The mesh is gone. And what's left behind is collagen that forms in the abdominal wall that becomes stronger than what the native abdominal wall was.
Now, when do you make these decisions as to what kind of surgery it's going to be? Is it one of those situations where you have to get into the cavity to see exactly what is necessary to be done, or is this something where you can say, hey, we're going to be doing the mesh today?
Pretty much for most hernias that we do throughout the world, the American Hernia Society and the European Hernia Society both advocate the use of mesh for hernia repairs. And then in terms of the type of mesh, there's data that supports one mesh versus another mesh, and everybody's got their preference, and they all work well. So what we kind of agree with is that in certain hands, each mesh has good favorability or bad favorability, and that's why most surgeons will do things the way they do.
Now, when you do the reconstructive surgery, is that one of those procedures you can do robotically?
Yes. So as the years went by with these larger hernias and more complex hernias, so hernias of the abdominal wall, make an analogy to college courses. You can have abdominal wall hernia reconstruction 101. So when you start talking about these large hernias, and then you're on your abdominal wall reconstruction 401. So they become more complex, and there are some surgeons that have kind of taken this as a specialty within the specialty for that. And for the most part, this is a procedure that allows or kind of causes us to create the dissection of the layers of the abdominal wall, and then reconstructing those layers. We have the abdominal rectus muscle, the so-called six-pack of the abdomen, the internal obliques, the external obliques, the transversalis muscles. These are various layers of muscle that make up the abdominal wall. And each of those muscles have a function for normal everyday life in what we do and how we turn and so forth, and even breathe. So in reconstructing some of these large hernias that have gaps of we'll say anywhere from 8 to 15 centimeters. We're talking about 5 inches to even larger than that. It's not easy just to sew those two edges back together again, because you create so much tension. The normal forces of the internal and external oblique are to pull the center away from the middle of the abdomen to make these hernias even larger. So the techniques that have evolved are these techniques where you relax the muscle on the outside, the internal, or rather the external oblique muscles, or the transversalis muscles. These are the deepest muscles of the abdomen. And that allows a tension-free repair where you're able to close the middle. And then certainly supporting it with the mesh is where we get recurrence rates that are less than 10%, even less than 5%.
You're listening to Peconic Bay Medical Center's Ask the Medical Expert. We'll be back with more in a minute.
Yeah. Sorry, I just get long-winded after.
No. I'm looking at the clock. I was like, make this? In post-production,
I wasn't even looking at the clock. I got to look at the clock.
Take a little peek every now and then.
Yeah. I can turn it this way a little bit, can I?
Yeah, whatever you need to do.
Yeah, just so I can see it.
just kind of seeing what the questions are based on some of your answers, so we're not repeating ourselves.
Right.
You know.
All right, I've answered it all now. So
Right. Now, if somebody would somebody send, like a gastro doctor, send a patient to you?
it would primarily from their medical doctor, doctor, or for these large hernias, they've even come to me from other surgeons.
Right. So do you have regular office hours and stuff like?
Yeah.
So if somebody says, "Hey, I think I feel something," would they come to you, or would they have to
Yeah.
the general physician?
Yeah, I've been known as the hernia guy.
If you think I got a hernia, okay, just so I can, say call your office or whatever, and
Sure.
that sort of thing.
Is my office number there? No, it's not there.
No, but that's something that.
I'll just. There's only one phone number there, as much as there's 3 offices.
You got offices in 3 locations?
Yeah.
Look at you.
It's too many.
Do you ever show up in an office and realize, oh shit, today's...
Sometimes I'm driving somewhere and I realize that, no, I got to go the other way.
You ready to continue?
Yeah.
You all ready?
All right, let's do this. And 3, 2, 1, go.
And welcome back to Peconic Bay Medical Center's Ask the Medical Expert. I'm Bill Powers on 103.9 LI News Radio. And today we're having a conversation with Dr. Agostino Cervone. He's the Chief of Robotic Surgery for Peconic Bay Medical Center. And Doc, say you're feeling like a certain issue. Can I come to you directly, or do I normally go to my general practitioner first? I would imagine that's how most people get the hernia diagnosis, is through their general practitioner.
I would agree with you. I think that for the most part, or unless you've had a family member that have had a hernia that was treated by me or what have you, they would kind of self-refer you to call the office.
Hey Bob, call the hernia doctor.
That's right. But for the most part, I mean, a lot of this happens through your general practitioner. They examine you, find a hernia, or you have a complaint of something that you don't know what's going on. And they'll diagnose it with the hernia, and then they get the referrals that way. So I would say primarily your primary physician.
Okay. And if they wanted to reach you directly, what if they decide to just go right to the source?
Oh, sure. I welcome any person coming into the office, and they'll call me at the office. 631-284-9250 will be direct line to my office, and I'm at 3 locations in Santa Mauritius, Manorville, and Riverhead.
And you also have a website as well?
I do. It's www.agostinocervonemd.com, and on there you'll find some information as well, including videos of some procedures I do.
Oh, really?
Yeah.
Wow. Now, when you do the robotic surgery, is that considered minimally invasive? Is it open surgery? Is it, explain exactly what it is, what kind of surgery, and what kind of recovery time you get from actually each procedure?
Sure, it's considered minimally invasive, just to cut to the chase, but I'll tell you a little bit more about that. So what used to be done with open operations, having surgeons' hands reach into your belly to do things, has then converted 25, 30 years ago to laparoscopy, where essentially we put little tubes in through the skin into the abdomen, and through those tubes we pass instruments to kind of do what we have to do. So now you're working with basically long instruments that you're holding on to. That over the years has then become translated into what we do robotically, which is still using those tubes, which are called trocars, and passing instruments through those trocars. And so it's the similar techniques as laparoscopic surgery, with the advantages that the robot bring. And those advantages are the instruments articulate, they're wristed, so you can reach around things. There's high definition visualization, that we can see things clearer, as well as everything is 3-dimensional in the console of the robot. So for instance, laparoscopy, you're translating a monitor that you're looking at, which is 2-dimensional, from a 3-dimensional field of the operation you're performing. So you may want to reach for something and you realize, oh no, it's not where I just try to grab, it's a little bit further there. And for those of us that do a lot of laparoscopic surgery, we pretty much get through that without realizing it. But anyway, robotics makes it even more in the way of an ease of every particular move is very defined.
And in that case, you only have to make one incision as opposed to laparoscopic. Normally, you have to make, they're very small, but they're 2, 3, maybe 4 incisions.
For some procedures, single incision is one way we can do it robotically. So, for instance, gallbladder is what I do a lot of also. I do them single incision gallbladder robotic surgery, which is just through the belly button. You don't even see those incisions. And GYN, for instance, have been doing single incision hysterectomies, whereas in the past everything was done open. So for the cosmetic standpoint as well as pain, that becomes an additional benefit. But for some of the complex hernia stuff, it is still multiple, 5 millimeter, 8 millimeter incisions to pass these trocars through.
We're speaking with Dr. Agostino Cervone. He's Chief of Robotic Surgery for Peconic Bay Medical Center. And if you have a hernia surgery, we kind of mentioned it. I guess it really depends on the mesh and stuff. What are the chances of it reoccurring?
So depending on the type of hernia, depending on a number of risk factors, we know that smoking is a risk factor for recurrence.
You know, I've learned why I'm a radio announcer, not a doctor, because... I apologize.
Also, obesity is a risk factor for hernias. Recurrence, somebody who coughs a lot certainly increases the abdominal pressure the most, and that their higher incidence of recurrence. Also, the size of the hernia originally that was presented to the surgeon, and then certainly the techniques that are performed in repairing these hernias. So that's where these complex abdominal wall reconstruction procedures kind of came in, because there have been enough failed repairs because perhaps that patient maybe was treated one way, either laparoscopically or open, depending on how it was treated. It probably created too much tension for that patient, and so abdominal wall reconstruction probably may have been the better procedure at the time. And then certainly as these hernias recur, then they become more complex, and then certainly that is the way to do it.
Now, what is the normal recovery time for each? I know everybody heals differently, and it depends on size of hernia and stuff, but under normal circumstances, between open, laparoscopic, etc., what's the normal recovery time? And if you have to have something done, what is the normal? Obviously, it also depends on what you do for a living, but how long would you be at work?
So most times I'll tell people to consider 2 weeks where they don't have any obligations. And that's, for the most part, the most common procedure that I'm doing is inguinal hernias, groin hernias. Whether it's done open or laparoscopically there's less discomfort, less time that you may need to stay away from work as opposed to an open procedure that's been documented. And in addition, it allows you to repair both sides in case you have a bilateral hernia. For those, I tell people about 2 weeks time where they don't have any obligations. I find that if you work for yourself and you're motivated, you're taking 5 days off. If you've got the time and you want to take more time, people are going to take longer than the 2 weeks. And certainly it all depends on what their vocation is in all of that. For abdominal wall hernias, depending on the size, usually about the same. As we get into the larger hernias and the abdominal wall reconstruction, it's probably going to be more in the line of 6 weeks.
And obviously, because you use your abdominal for so many things, that every single move probably hurts.
Yeah, and that's only recognized after you have abdominal surgery.
You should have told me, Doc, ahead of time. Now, how do you prepare for a surgery like this? Is there anything special preparations that have to be done by the patient as they get ready for this type of surgery?
Yeah, so everybody goes through a preoperative clearance process. Certainly, if you have heart disease, you're going to see your cardiologist. Even if you've not had heart disease and you're of a certain age and certain maintenance that we end up doing, that becomes part of it. If you've had lung disease, that becomes a big part of it also, because a lot of our ability to breathe involves our abdominal muscles, and so that could become a problem afterwards. So those are bits of it, as well as all surgery constipates people. These are the conversations that we have at dinner time sometime. Tell them ahead of time to have something available, or if it's really bad, do something even before the surgery to get you prepared for that.
Maybe go for a colonoscopy ahead of time.
Well, at least clean yourself out, maybe.
Just kidding. Okay, now after the surgery's done, what do you need to do to get back on your feet during the recovery? Do you need some kind of medical equipment? Do you need maybe like stomach massages or anything like that? What do you need to do during the recovery to aid in the recovery?
I would say just ambulate, just move around for the most part. For most general hernia repairs that we're doing, we just try to motivate you to get up and move around as much as you can. I tend to not limit people after hernia surgery. Their barometer of what they do is how they feel. So if it hurts when you do it, then maybe hold off on doing it. And I would say that the more you ambulate, the more you kind of work through the discomfort that you have, and the faster you're going to recover from it. Certainly, you don't want to do anything too crazy, but within reason, you should be able to do as you tolerate.
Yeah, I guess it's not a rumor then, when you have hernia surgery or whatever, you can re-rip it or re-tear stuff if maybe you lift things that are too heavy or something, or strain yourself in some manner.
Yeah, certainly that is a concern. But with that, so if you're one that say you're a gardener and you're ripping out shrubs, and you're going to rip out shrubs 2 weeks after having hernia surgery, and you're working through the discomfort that you're having, there's a chance that, yeah, you can do that. And hopefully I've fixed it well enough that that's not going to happen even if you're doing that. But at the same time, I would say that for the most part, it's not controlled movements. It's not controlled lifting. It's probably episodes where say you're falling off a ladder and all of a sudden you have to torque yourself in such a way that creates such forces on your abdominal wall that perhaps something like that may do
So
a little bit of that.
quick motions, quick actions.
Correct.
Gotcha.
Correct.
We're speaking with Dr. Agostino Cervone, Chief of Robotic Surgery for Peconic Bay Medical Center. And doctor, if somebody wanted to reach out to you directly, can you give us the phone number again?
Sure. My office number is area code 631-284-9250.
And you have a website as well?
Website is AugustinoCervoneMD.com.
And 3 convenient locations, right?
Yes, I'm in Santa Mauritius, Manorville, and Riverhead.
Doc, thank you so much for coming on in. We appreciate it. You've been listening to Peconic Bay Medical Center's Ask the Medical Expert. I'm Bill Powers for LI News Radio 1039. Did I really just screw up the one thing that I should freaking know?
Last, yeah.
The call letters. Can we just record that one a little bit?
We got to do the whole thing all over
The
again?
whole thing! The John Gomez show is being preempted because Bill Powers is a meathead.
Whatever you're ready.
Wow! You've been listening